Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld, and welcome to our first live in the month of June. I am so happy to have you all here. So we're going to enter a big testing season in June and July. So we're going to prioritize some pretty big critical NCLEX concepts. Today we're going to look at a prevalent neuro concept, and that is traumatic brain injury. We're just going to call it TBI for short because it's kind of a mouthful. But TBI is the leading cause of death, a leading cause of death for both adults and children. Many of you guys watching may know someone who's had a TBI. You may have had one yourself. After all, a concussion is a type of TBI, and concussions are really prevalent, especially for anyone that was sporty or played sports growing up. So before we get started, a couple of housekeeping things. If you haven't already, follow us at UWorld Nursing on whatever your preferred social channel is, so you don't miss any of our live lectures or question drills going forward. Also, keep letting us know the topics that you want to see us present. We do take into account the topics and the body systems that you all are interested in and that you want to see in our lives. So keep letting us know in the chat what those will be. This live will be on demand after we're done, so check into any of our social channels, specifically that YouTube channel. I think is the easiest one to search with the search bar. So you're always able to tune back in case you missed something or I went too fast over a certain topic. As always, drop your comments, drop your questions, and of course your answers to today's questions into the chat. We have the wonderful nurse Jasmine moderating for us today. So even if you just want to stop by and say hi, please use that chat feature. Alrighty, and let's get started by letting us know where everyone is joining from. Who is joining us from the good old US of A? Who here is an international viewer? We are so excited to have you regardless of where you're from. So keep letting us know where you're coming from. And I already see a couple of people putting in the topics they want to see us present on. So thank you guys so much for using that chat feature, and let's keep it going as we get started on today's material. So let's look at that overarching patho behind TBI. A TBI can be open or it can be closed, meaning it can occur with or without a break to the skull. Now, an open TBI would also be referred to as something called a penetrating brain injury. So if you ever hear that, you'll know what it means. Now, TBIs can result in either temporary or permanent brain damage. Temporary brain damage would typically result as like an altered level of consciousness. It would typically resolve itself, that's why it's temporary, and the client eventually returns to a normal level of operation, level of consciousness. Now, permanent brain damage, unfortunately, will result in long-term impairments like cognitive, physical, and psychosocial impairments. We're going to jump to our types of brain injuries table. It lays this all out for you guys. Again, any of these visual references, you guys are free to screenshot, take it with you for the future. But we're going to walk through these, and they kind of get more severe as we go on. It's a spectrum. So we're going to start out with concussion. This is considered a mild TBI, and it's a pretty common injury. I think it's gotten a lot more kind of airtime in the past years after we're seeing some of the long-term effects of concussions and like CTE in the NFL, for example. But this will result from a mild blow or bump to the head, maybe a small fall. It can produce a brief loss of consciousness, or it can also present with no loss of consciousness at all. Symptoms here include things like headache, dizziness, and the potential for amnesia. Now, interestingly enough, a CT scan will not show injury to a brain. So a client may suffer from a concussion, but that CT scan isn't going to show any changes, and symptoms here will typically resolve within 3 days. Now, the next step up here is a contusion. Now, this is a bruise of the brain. It's a focal injury, meaning that it's localized. And interestingly enough, the symptoms are going to vary based on the location of the brain. So we know we have different language centers in our brain. We have a hearing center. Depending on where the contusion is, that's what's going to dictate what the symptoms are. Moving on up to a diffuse axonal injury, or a cerebral edema is another way this is referred to. Now, the most common culprit here that causes this cerebral edema is going to be a high-speed motor vehicle collision. That's a very common cause of this. It causes shearing of the brain's hemispheres. So essentially what this means is as the brain and the skull are whipped back and forth due to those crashing as well as the braking forces, one pushes you forward, one shoots you back, it causes shearing bridging of those white matter tracts, which is what connects the left and the right side of the brain, allowing them to communicate to one another. Now, what this leads to is diffuse brain swelling and can result in a severe DAI or diffuse axonal injury, and it can lead to coma. Unfortunately, this is a high mortality injury. If a client does survive this, often they are left in a vegetative or a coma-like state. Alrighty, moving on to skull fractures. So skull fractures can present in a couple of different ways. There can be a linear skull fracture, meaning it occurs across the suture lines of the skull. We can have a depressed skull fracture, meaning it pushes down a piece of that skull inwards to the brain, which can actually injure that brain tissue. And it can also be comminuted. This is meaning that the bone from that skull has shattered into smaller pieces, into multiple pieces. All three of these fracture types can lead to injury of that underlying brain tissue, which is important to note. Now, the skull fracture has a couple of different really hallmark signs, and I want you guys to bookmark this because we're going to go over it in more depth in just a few minutes. But lastly, I want to cover hematoma. We're also going to cover this at the end of the lecture in more depth, but just a quick overview. This is bleeding in the brain. There's a couple of different pockets of the brain this can bleed into. We can have epidural hematoma, subdural hematoma, or an intracerebral, which would be bleeding deep within the brain tissue. Alrighty, so we've talked about these different qualifications, the buckets, so to speak, of traumatic brain injuries. Now, what are the clinical features of this going to look like? What are these clients going to present with? Now, important to note is that symptoms of TBI are mostly due to brain swelling that contributes to increased intracranial pressure. That intracranial pressure, or ICP, is going to be a word you hear a lot from here on out in this lecture, but again, this is where a lot of these symptoms are manifesting from. So symptoms include things like nausea, vomiting. Really important here is that increased ICP can cause projectile vomiting, and I can promise you, once you see that for the first time, you will never forget it. It truly is projectile. Clients can have worsening headaches, really intense, severe headaches, increased drowsiness, like difficulty arousing. They can be just confused and disoriented in general. Clients can see behavioral changes, things like anger and irritability, having really labile emotions. They'll have motor problems, maybe slurred speech, weakness in their extremities. Clients can present with sensory disturbances like numbness. They can have visual changes like blurry vision, sensitivity to light, which we call photosensitivity. And clients can also present with pupillary changes. So this can be dilation of the pupils, it can be constriction of the pupils, which of course changes the size of the pupil, and it can be seen bilaterally, meaning in both eyes, or unilaterally, just in one. Clients with TBIs are also more likely to have seizure activity, which is so important to make sure we enact and maintain our seizure precautions. And we diagnose those brain injuries, head injuries, typically with our CT scans. We can also do gradual scans to see if this client is improving or if they are decompensating. Alrighty, let's go ahead and jump to skull fractures. So again, I talked to you guys about, we have a great slide here, screenshot it, take it with you, but skull fractures have some really unique hallmark features that are going to aid you to be able to identify this not only in a clinical setting, but also we're talking about that NCLEX. A lot of you guys are testing soon. I want to make sure you guys know these red flags for basilar skull fracture so you know how to identify it on a question. So first off, one thing we're going to see is something called battle sign. This is the bruising behind the ear in that like mastoid portion of the skull. We can see raccoon eyes, which is exactly what it sounds like, that black eyes bruising around the eyes. And we can see leaking of cerebrospinal fluid, or CSF. Now this can leak from the nose, it can leak from the ears. It is a clear fluid on its own, but because with a TBI, we may have some sort of trauma, it can be red tinged from added blood. But cerebrospinal fluid, or CSF, on a piece of gauze will leave a halo sign. It has that little ring around it, and that's a great way to know that it's CSF and not some other type of, just regular nasal drainage. All right, so a quick question for the chat. I'm going to challenge you all now. So when a client has a skull fracture, or maybe a suspected skull fracture, what kind of tube is contraindicated? So in our clients who have skull fractures or a suspected basilar skull fracture, what kind of tube are we going to not use, is dangerous to use? Let us know, drop those answers in the chat. See what you all are saying. Alrighty. Keep them coming. Someone says, I want to be in the chat, please. You already are. Great job. Way to go. All you have to do is participate. You're doing great. And you guys got it per usual. You are so, so smart. That NG tube, the nasogastric tube, is what would be contraindicated for a client with a basilar skull fracture. So with basal skull fracture, there's severe trauma to the bones of the skull, which are behind the face. The nose, i.e. a nasogastric tube, and the brain are pretty close together. If that bone integrity is compromised, if we have that basilar skull fracture, the NG tube, while we meant to put it up the nose and it goes down the esophagus, it can actually go through those bones that are broken or that the integrity is compromised, and we can actually intubate the brain rather than going down the esophagus. So we want to make sure we are not inserting NG tubes on our clients with skull fractures. Alrighty, so that sums up our basilar skull fracture part of today's lecture. Let's jump to our hematoma section. So we have a great slide that combines the epidural hematoma and the subdural hematoma, kind of lets us compare and contrast here. But in epidural hematoma, here the blood accumulates between the dura mater and the skull, so it's a little bit more superficial. The cause of this is arterial bleeding, and because the bleeding comes from an artery, the neurological symptoms that come on are going to come on very quickly. It's much more acute. So we can have rapid hematoma expansion that really quickly increases our ICP, which is what contributes to the manifestations of neurological decompensation. So we can see with these epidural hematomas that quick, really acute onset of change in level of consciousness, or LOC. Clients will have quick, severe headaches, nausea and vomiting, and remember that increased ICP hallmark sign is projectile vomiting. Now this is an emergency. There is a need to act very quickly. These epidural hematomas, because it's arterially based bleeding, require surgical evacuation. Ideally, we want to identify it quickly and get this client into surgery quickly. Now, subdural hematoma is a little bit different. So here blood is accumulating between the skull and the brain. So it's underneath that dura mater. It's a little bit deeper than our epidural. It's subdural. The name explains it all. So it's caused by venous tearing and bleeding. Now, expanding hematoma leads to increased ICP, and eventually it can compress the brain. Now, this is a little bit different than the epidural because it can present in a couple of different ways. It can be acute if there's a lot of veins involved, a lot of vessels involved. Remember, it's venous tearing and bleeding that causes the subdural hematoma. However, it can also be slow, subacute, or even be considered chronic if only a few vessels are involved and contributing to the bleeding, and they're doing so very slowly. Now, our nursing interventions, what are we going to do for these clients? We always use something called the Glasgow Coma Scale, or the GCS. You may hear someone ask for what's the GCS score. This is used to determine the symptom severity using the client's verbal and motor response as well as their eye-opening abilities to assess where they are neurologically. So the lower the number of the GCS score, essentially the worse off the client is. 8 or below indicates a coma-like non-responsive state. Now, a mild TBI will be a score of 13 to 15, a moderate TBI will be 9 to 12, and severe TBI, again, is anything less than or equal to 8, meaning there's not a lot of function going on. This client most likely needs intubation for some respiratory support. So we also, for our nursing interventions, always want to assume and stabilize the neck because we want to make sure that we rule out a neck injury before we move this client's spine. So we're always going to assume a neck injury until we can officially rule it out. We want to stabilize that cervical spine using something like a hard collar to keep it stabilized, midline, and in place. Monitor the client for increased ICP. Remember, projectile vomiting, headache, changes in LOC are all key signs of this. Clients will most likely need some sort of supplementary oxygen, and we want to ensure IV access. So ideally we'll have 2 large bore IVs, and clients will receive some fluids, usually 0.9% sodium chloride. These are all things that we'll do for these clients. We also want to help them maintain normothermia. So depending on the area of the TBI, if it's one of the centers that maintains homeostasis, their temperature can be affected. It can make it hard for them to regulate their own temperature. So we can step up with our exogenous implementations. We can give them blankets, warming blankets, maybe like warmed IV fluids to help them keep their temperature up. Intubation will be required for clients who have those GCS scores of 8 or below because they need some mechanical ventilation because their respiratory drive here is most likely depressed. Again, they have very minimal abilities, or 8 or below indicates coma-like state, so we're going to need to help their respiratory drive by using that mechanical ventilation, which gives us a little bit more control over their respiratory drive and gives them that support that they need. A key assessment for any neuro nurse is going to be pupillary assessment. So we are continuously checking for size. Are they constricted? Are they dilated? Are they reactive pupils? Is it a unilateral change? Is it a bilateral change? We also want to assess for that rhinorrhea and ear drainage for the potential of that CSF fluid leaking. So remember, we're going to check, and if it's the halo sign on a clean piece of gauze, that's how we know it is CSF. We want to check for any scalp wounds, any open skull wounds, make sure it's not only internal damage, assess for the external damage. Do they have a break to their skull that we can see? Now, CT scans, we talked about those being diagnostic for TBIs. They're also going to be done serially to check the status of the client's condition. So this is how we know, are they getting better, or unfortunately, are they decompensating and getting worse? Now, depending on the results of the CT scan, some clients may require further surgery. Some things we can do is implement an IVC, or an intraventricular catheter. This can be placed in the brain to monitor that ICP continuously to prevent any further brain damage. Essentially, it's a real-time monitor of where the ICP is. It's a similar concept as like an arterial line that measures real-time blood pressure in a client's heart. This is going to measure real-time, ICP in a client's brain. All right, so positioning. We want to position the head of the bed slightly elevated at about 15 to 30 degrees. The exception to this are any spinal injuries. We also want to keep that head midline, avoid any neck flexion or neck extension. Now, common medications we see to control these neuro injuries are going to be based around decreasing that ICP. I'm going to ask another question to the chat, but what's a really common diuretic medication that's used to decrease ICP in a neuro setting? So you're going to see this diuretic given so many times in a neuro ICU and any kind of neuro setting. So drop those answers in the chat. Alrighty, and I see some great answers. You guys are spot on per usual. Mannitol is what I was looking for. So this is an osmotic diuretic. It's given IV typically, and its mannitol is going to help decrease that ICP, that intracranial pressure. How it does this is it pulls fluid, that extra fluid volume from the brain back into systemic circulation, and then it allows the body to diurese it. Now, a couple of key things to remember about mannitol is that it can crystallize, especially at low temperatures. So we always want to make sure we're storing our IV mannitol at the correct temperature, whatever the pharmacy tells you to do, and we want to check it before administering it to make sure it has not already crystallized. Other nursing interventions for our neuro patients are to monitor and prevent complications. Keep a close eye on these patients. A lot of neuro ICU patients will be Q1 hour rounding, so really takes a lot of assessment, a lot of vigilance to keep these clients healthy. Clients are also more likely to experience seizures, so they need to be on seizure precautions. Brain injury and increased ICP can both lead to seizures. So some of our seizure precautions include removing anything that could injure them if they were to seize, any sharp objects, any utensils, pens, pencils, maybe medical equipment. Any restrictive clothing can also be dangerous if they were to seize. If a client does seize, we want to put the head of the bed flat. We want to call in some buddies. Most importantly, nothing by mouth. So while they're seizing, we don't put suction in at that time. We don't put a tongue blade in. They could bite it off. They could aspirate. It could injure them too, some of the soft tissues in the mouth. So nothing in the mouth while the client seizes. We're going to lay them flat. We're going to document the characteristics of the seizure, the timing of the seizure, and then after they're done seizing, then we can do maybe some suction to get out any excess things that have been coughed up. Maybe it's saliva, maybe it's blood from the seizure. Fever and infection, so increased metabolic rate can increase ICP. So we want to make sure if that metabolic rate is increased from things like fever and infection and illness can lead to this. We know they're at a higher risk of also having high ICP, so keeping a close eye on that and keeping our hand washing precautions and our infection control precautions in place to prevent any infections. DVTs can also result. So a lot of these clients, especially the ones with those GCS scores that are really low, 8 and below, are going to to be in a coma state. They are obviously, if they're in a coma, they're going to be sedentary. So our DVT prophylaxis is important. Now, of course, this can be mechanical, like a SCD machine, but it can also be chemical if we want to use a heparin or a Lovenox. And lastly, stress ulcers can develop, so we're going to need to give appropriate GI medications. Alrighty, so let's move on to our craniectomy image. Alrighty, so let's look at this. This is one of our other interventions to help decrease the ICP, but it is a very specific procedure that has some specific protocols afterwards, some nursing care. We need to make sure that we understand for these clients. So a craniectomy involves removing a piece of the skull in an effort to decrease the client's ICP. Essentially, a surgeon will take off the piece of the skull and then reclose the skin and the muscle layers over that area without the underlying piece of bone. Now, while this allows ICP to decrease because it allows that brain to expand if it needs to without hitting up against the skull, it does also leave the client very vulnerable to injury. Again, we don't have that protective skull as a barrier there anymore. Clients should always be positioned on their non-operative side or on their back, but never on the operative side. Again, there's nothing to cushion the brain as that a hard piece of skull has been removed, so we have to make sure we take extra care to protect it ourselves. We want to monitor our drain output and monitor their head dressing frequently. We're looking for keeping close eye out for signs of infection, like maybe a green or a yellow discharge. You never want to get an infection anywhere, but especially not in your brain. We also want to monitor the output. Is it frank red blood? Is it increasing in volume? Is there potential for hemorrhage here? All right, guys, you have done fabulous today. So let's go ahead and bop to our first question of the day. And that one is going to be about TBI. So the nurse is observing a staff member for a client who sustained a traumatic brain injury without cervical spine injury. The nurse should intervene if the staff member is observed. Our options are turning the client using the log roll technique to remove soiled linen, 2, checking the client's pupils for size and reaction to light, 3, monitoring the client's gag and cough reflexes, or 4, placing the client in the Trendelenburg position. Alrighty, so drop those answers in the chat. Let us know what you all are thinking. Alrighty, and in the meantime, we are partnered with NSNA. Now, we have talked a lot about this in our past lives, but not only we have a really big presence at their spring and fall NSNA conferences, we're also doing virtual webinars. So for anyone who's not able to join us in person in Seattle back in April or in Columbus, Ohio this upcoming November, you are able to join virtually. Visit our social media at UWorld Nursing, or you're able to visit NSNA's social media for more information. Our next webinar is going to be on Monday, June the 9th, so it's coming up next week. That's 11 a.m. to 1 p.m. Central Standard Time, and after that we will be doing another one in July. Those are sessions 3 and 4 out of 6 throughout the calendar year. So make sure, this year is just flying by. Make sure you sign up for that one because before you know it, this year is going to be over. Alrighty, so lots of great answers coming in, and per usual, you all are spot on. Option 4 was our correct option. So remember, this is an intervene question, meaning we're looking to identify an incorrect action. So option 4 was our incorrect action. It requires intervention because it's incorrect. So Trendelenburg position is going to be with the foot of the bed elevated. The head of the bed is going to be down. So essentially, our feet are going to be higher than our head. This is not good for ICP. This is going to have more volume, more blood flood into that head and further increase our ICP. We also want to be avoiding flexion and extension of the neck. We want to maintain the neck in a midline neutral position for our TBI clients, and they do specifically state that it's without cervical spine injury. In this case, we want to keep this client about 15 to 30 degrees of elevation. Too high is going to cause hypotension, too low is going to cause that increased ICP. But whenever we're adjusting the height of the bed, really important to do it slowly and not quickly, which would prevent worsening injury. Alrighty, so options 1, 2, and 3 don't require intervention. They are A-OK interventions. We want to turn the client using the log roll technique because it keeps the head in a neutral position. As we turn the client using the log roll technique, it keeps everything in line. So we're not torquing that, abdomen one way while the head remains the other. It's keeping it all in line and not further increasing our ICP. This is a good intervention. Option 2, we want to check the client's pupils. This is a great indicator of brain health. We're going to check size. Are they dilated? Are they constricted? Are they reactive to light? Is there a unilateral change? Is there a bilateral change? Pupillary assessment is going to be a huge tool in the arsenal of a neuro nurse. 3, monitoring the client's gag and cough reflexes. Another thing we're going to do, we always want to make sure we prevent aspiration. We understand if the client is able to gag or to cough, meaning they would be able to cough up an aspiration and prevent from aspirating or choking on something. So again, option 4 was our correct option. Way to go. All right, final question. The nurses attended a staff education program about seizure precautions. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. Our options are: I should ensure there is suction equipment in the client's room. I will document the duration and behavior observed during a client seizure. 3, I will raise the head of the bed during a seizure to protect the client's airway. 4, I will activate the call light and request assistance if the client is experiencing a seizure. Or 5, I should insert a tongue depressor in the client's mouth during a seizure to prevent injury to the tongue. Drop those answers in the chat. And I see someone asking if we have payment plans available. We do have payment plans available. We use Affirm. You are able to break up your monthly payments to as little as $13 a month. So make sure you take advantage of that. It's available wherever you go to on uworldnursing.com. You can get a link to our product and it's available there. I think it's underneath it. It allows you to break it up using Affirm. So we do have a payment plan. I know that this is a kind of a tight financial time for a lot of our nursing students, and we want to make sure that we're being amenable to that. So we are able to break it up in the payments. We have a 7-day free trial. Also visit uworldnursing.com for our complete live presentation schedule. We give away a lot of free resources here on these lives. We're doing them 6 days a week, 5 days a week now. So lots of opportunities to take advantage of these free resources, free questions, and free lectures. Alrighty, so I see lots of 1s, 2s, and 4s, and occasionally I see a 5 mixed in. So let's go over this. Our correct options were 1, 2, and 4, not 5. So this is kind of confusing, and I feel like the way this question is worded, maybe it was meant to trip you up a little bit. But here in this case, we're talking about seizure precautions. So clients need to be in a safe place, ideally on their side, with padding under their head. The side rails should be padded as well. We want to keep the head of the bed flat if a client starts to seize. Any restrictive clothing needs to be removed. Any objects that are sharp or could harm them, maybe they're just really hard, we want it to remove from the client's vicinity. The priority is to stay with the client, call in some help. We want to keep track of things like the duration of the seizure, the characteristics of it, and we want to document the post-ictal phase or the post-seizure phase as well. We do want to have our suction set up for after the seizure to help clear the client's airway of any post-ictal, maybe aspiration from like saliva or blood, but during the seizure, we do not put anything by mouth. So make sure we note that nothing by mouth during a seizure. The client could bite it off, they could aspirate, it could damage some of the soft tissues of the mouth. So again, we're not putting anything in, including a tongue depressor during a seizure. So again, 1 was correct. We want suction equipment in the room. We don't insert suction while they're seizing, but afterwards we can use this. You do want to document in option 2. In option 4, you definitely want to press that call light, get some buddies in to help you out. So again, 1, 2, and 4, way to go. Alrighty, so quick little view into our week. Tomorrow we're back with, we're going to be doing a concept map as well as a select all that apply question drill, so make sure you tune in for that. Thursday we'll be back with hematology questions as well as Friday, and on Sunday we're going to be doing prioritization questions with Nurse Andrew. So quick little look at our QBank slide. Now this is great for all of our viewers who've already purchased our product. Here is how you make sure to navigate to more questions based on what we learned and talked about today. So here's how you can filter to more neuro questions. For anyone that has not purchased our product, here's a little keyhole into what we offer. This is just one way to filter all of our different questions. There's so many ways to combine them and make sure you are targeting the area that you specifically want to be studying and practicing questions on. UWorld is our premium product, so make sure for your NCLEX study purposes, you are checking UWorld out. Someone says, does anyone have the link to the webinar? Check out our Instagram page. I see it's Hannah Decker on Instagram. Go to the UWorld Nursing Instagram at UWorld Nursing, and we have one of our first posts is going to be information for that NSNA webinar. We would love to see you there. So with that being said, thank you so much for staying tuned. I hope you all found this to be helpful. Neurological concepts are pretty complex. Mastering the content that we talked about today does take some dedicated study time, but you guys did so well today. Way to go. Again, we're going to be back tomorrow at 11 a.m. and 7 p.m. Central Standard Time, and I look forward to seeing you guys there. Bye-bye.